So this is a 65 years old male who is a known case of diabetes, hypertensive and smoker. He presented with 6 hours of chest pain and with in ECG with the evolved inferior wall ST elevation MI. So this is angio, and you can see this is with right radial root, and this is RCA, and you can see how thrombotic RCA with right from the proximal to mid there is a thrombus loaded RCA, and flow is there, very minimal flow is there in the distal RCA. So if you see carefully the mid RCA, there may be a aneurysm, that is a possibility, or thrombus. So you should be very careful while passing the wires and all. If it is aneurysm, then it may perforate. So we thought of aneurysm or thrombus, and then we were very careful while passing the wire. This is again with the MAC shot, magnification shot, and you can see the very minimal blood flow in the RCA. But right from the ostium to proximal mid RCA, there is a thrombus. And this is the iliocaudal view, and you can see there is a calcification in the proximal osteoprox LAD and showing different view. So if you see, there is a right from the ostium of the LAD to proximal LAD, there is a significant stenosis, almost 80-90% stenosis is there, which is the calcified. There's again the caudal view, ariocaudal view, and you can see the same thing in the osteoprox LAD. There is a calcified stenosis, and this is a epicranial view, and you can see the same thing in diagonal also. You can see the occlusion, almost 90% occlusion in the diagonal T1. There's cranial view, and you can see the same thing. And I didn't have any luxury of imaging in this patient because it was a state sponsored scheme, so didn't have any imaging. So I wanted to do the imaging for this calcium, how much it is, how much deep it is, or superficial, or anything else, but I didn't have any luxury of doing imaging in this case. So with the right radial root with this JR catheter, right catheter, we went ahead. This is a BMW PTCA wire, and I was trying to cross the wire, but the thrombus was organized, and I had a doubt of having aneurysm, but after sometimes it is confirmed that it was a thrombus only. So after some time, after 5 to 10 minutes, flow has come, and wire was not crossing, but I was trying crossing the wire. This is same BMW PTCA wire, and after around 15 to 20 minutes, I crossed the wire with the same wire, BMW PTCA wire, and there was no any aneurysm. This was a thrombus only. So you can see the flow now, the plane RO view, and you can see the same thing. This RV branch is so large, and you can see the thrombus in the right from the proximal to mid RCA. So after all clearance, decided to put a stent. The stent is 3x24 stent. We didn't want to put this across the RV branch. Just before the RV branch, we put a stent. This is a stent placement. Wanted to put right from the ostium. So this is the iliocaudal view. Is the best view to see the ostium of the RCA. And the stent is being deployed. It was 12 atmospheric pressure, 8 was nominal, and 16 was RBP. And see the same thing after stent deployment. There's a slow flow, but this RCA has opened up and with slow flow. So there's always been a problem of slow flow in the ACS patient, and this is you can see how slow flow is there in the RCA. Patient was stable. Then we have given everything, terifluban, Nicoran, everything. Then somehow flow has improved, but it was with slow flow, and you can see how large the RCA is, super dominant RCA. So this is the final shot of RCA. You can see how large the RCA is, PDPLV, and this RV branch also. So we'll start the infusion of terifluban in this patient. Then as the patient was stable, and then we decided to do the complete revascularization with this LAD. This was a non-infractalated artery. This LAD is calcified. As I told, there was no luxury of imaging in this patient, so we decided to put a stent over here. We did it pre-dilatation. So if you see distal LED, there is a tortuosity in the distal LED. In such cases, there may be a chance of distal wire perforation or dissection. So you need to be very careful. So I made a sort of knuckle, but it didn't work. So anyhow, I placed the wire over there in that tortuous segment. As soon as I tried to push the wire, that catheter used to come back. So I kept wire over there only. And this was the stent of 3.5 into 24. And I can see in this iliocaudal view, right from the ostium, we decided to put a stent. Just we kept one marker in just ostium. We had that ramus also should not get compromised. So I put one end of the stent in the ostium LED and then inflated at 14 atmospheric pressure. 16 was RBP and 8 was nominal. So this is at 14 atmospheric pressure. So in this view, you can see some sort of under expansion due to calcium, but not significant. So we did the predilatation with cutting balloon also to cut the calcium, and then somehow we got this result. The result was good. You can see in this LED caudal view, the ostium of the LED and the proximal LED has opened up, and I think we cracked the calcium with this cutting balloon, and then this was a TIMI3 flow in the LED. So this was a PTCA to RCA, infracilinated artery, and then LED with a complete revascularization in this 65 years old inferior wall ST lesion in my patient. The patient was stable, shifted to ICU. Thank you.